Maybe let's get started. It is 7:31. This is Jamie McCabe. I have the great honor and privilege of introducing my newest partner, Christine Chung, our newest partner. Dr. Chung did her undergraduate training at UNC Chapel Hill. She then went to med school at Drexel, residency at the Brigham, and then general cardiology and interventional cardiology at Columbia. She won all sorts of accolades and ultimately was someone we were really excited to recruit in for a faculty position within our interventional cardiology group. She beat out a very competitive field and has only marginally regretted it ever since. So without further ado, let me welcome Dr. Chung.
Jamie, thanks so much for that kind introduction, and thank you to Rob and Greg and everyone in the division for this opportunity to speak to you today. As Jamie mentioned, I moved out here about 6 months ago with my husband and 4-year-old daughter. I have had a chance to meet and work with many of you, but there are still many, especially in the current era of social restrictions related to COVID, that I have not yet met. So if you do see me in the hallways, please feel free to introduce yourselves if I don't get to it first. For those of you who have seen me, I am clearly packing a few extra pounds. That's because I am currently 7 months pregnant with our second, who we are expecting in April. And in coming out here, it was my aspiration and intent to be a full-fledged structuralist, doing TAVR, MitraClip, PFO closure, as well as complex coronary procedures. But the focus of the talk today will be on a particular passion of mine, percutaneous left atrial appendage closure, and how it fits into the overall management of stroke risk in our patients with atrial fibrillation. I have no financial disclosures. So we'll begin with the case. This is patient WJ. He's a 69-year-old man with a longstanding history of mixed connective tissue disorder, has been maintained for many years on prednisone and Cellcept. He has a history of coronary disease. About 10 years ago, had a STEMI, treated with an RCA stent. He also has had longstanding AFib. Several years ago, he underwent an ablation and was previously on apixaban, which was tolerated for many years, and also has severe MR and HFrEF. His CHA2DS2-VASc score is 3, which correlates to a moderate to high risk of stroke, and a HAS-BLOOD score of 3, correlating to a high risk of bleeding. And although he had previously been tolerating apixaban without issue, he did one day wake up in the middle of the night with hematemesis, and by the time EMS got him to his local hospital, he was in frank hemorrhagic shock, requiring intubation and emergency transfusion of unmatched code blood. He ultimately underwent an EGD, which revealed a bleeding erosion in the lower esophagus that ended up being challenging to treat. They had to go through multiple rounds of coagulation, epi-injection, and clipping before attaining hemostasis. So at the time of discharge, he was off of all anticoagulation as well as even antiplatelets, including his aspirin. But by the time I saw him in the summer, fall, he was back on a baby aspirin and had not had any recurrent bleeding. So as we progress through our talk today, I'll just ask us to keep this patient in the back of our minds, and I'll keep circling back to him to illustrate some of the complexities of the decision-making that arises in the management of these patients. So to start, we'll have a brief overview of the epidemiology of atrial fibrillation. In reviewing the treatment indications and options, we'll really be focusing just on the aspect of stroke risk. We won't be discussing things like rate or rhythm control. We will focus a bit on the device landscape and some procedural details. And then we'll spend the bulk of our time reviewing the current literature of the pivotal trials and big registries and what they tell us about the safety and efficacy of this procedure. We'll discuss the post-procedural management with regards to adjunctive pharmacotherapy, as well as the surveillance imaging that is required, and then discuss some of the remaining questions and the ongoing clinical trials that seek to answer them. So as cardiologists, it will come as no surprise to any of us that AFib is very common. It affects millions of people in this country, and the prevalence does seem to be increasing, such that by the year 2030, over 12 million adults in this country are expected to be affected. The prevalence seems to be increasing over time, partly due to increased surveillance. So as our elderly patients are implanted with pacemakers and defibrillators, routine monitoring is turning up more subclinical AF. But also as the general population has increasing rates of other cardiovascular disease risk factors, things like hypertension, obesity, diabetes, these also impact on the lifetime risk of developing AFib. So some of the factors associated with new onset AFib are beyond personal control, things like European ancestry and a patient's height, but many of the population attributable risk factors are linked to behavior and lifestyle modification and can be modified by our therapies. So things like hypertension, obesity, smoking, cardiovascular disease, and diabetes have all been associated with increased risk of new onset AFib. And the degree to which we can control these other risk factors impacts an individual's likelihood of developing AFib. Once a patient has been diagnosed with atrial fibrillation, there are a host of associated complications whose incidence in general increases with advancing age. So things like heart failure, stroke, GI bleeding, and overall mortality continually increase with advancing age in the years after initial diagnosis. AFib is associated with a fivefold increased risk of ischemic stroke and account for a significant proportion of the strokes that we see in our older patients. These strokes tend to be more debilitating and are associated with higher mortality. In our patients with non-valvular AFib who do come in with a stroke, the left atrial appendage is the source of the vast majority of these cardioembolic thrombi. So what kind of guidance do we currently have in making these treatment decisions for these patients? So the most recent update to the AFib guidelines came in 2019 from the AHA, ACC, and HRS. In patients considered to be at lower risk of stroke with AFib, so for men that correlates to a CHA2DS2-VASc score of 1, and for women to a CHA2DS2-VASc score of 2, the current guidelines recommend considering oral anticoagulation or at least an aspirin. However, in patients who have at least a moderate risk of stroke, oral anticoagulants are recommended. Of course, when making recommendations and decisions for each individual patient, there's often a shared decision-making process that comes into play where we are balancing the risk of stroke with the risk of a serious bleed. The effectiveness of Coumadin in reducing the risk of stroke related to AFib has been well demonstrated in lots of historical studies. So warfarin reduces the risk of stroke by over 60%. And over the past several years, we've also amassed a large body of evidence that the DOACs are equally effective, if not sometimes more so than warfarin, at reducing stroke risk and other thromboembolic complications of AFib, and often with a better safety profile related to lower risk of bleeding. The challenges of safely and effectively using Coumadin in our patients is well known and has been well studied. The challenges of the narrow therapeutic range lead to complications being seen when patients are either sub or super therapeutic. Some of these challenges are obviated by the use of the DOACs. However, when considering the overall population of people with non-valvular AFib, there is still a significant minority, about 10% of patients who are contraindicated for anticoagulation due to either an established history of bleeding or underlying risk factors that significantly make it more likely that they will have a bleeding complication. One of the other challenges of oral anticoagulant use is that we as physicians have historically undertreated our patients who are otherwise eligible candidates for anticoagulation. So historical studies have shown that use of warfarin in the population of non-valvular AFib patients who would potentially benefit from anticoagulation hovers around 50%. This was a study of over 650,000 patients, primarily being seen in community cardiology clinics, and sought to understand whether the introduction of DOACs led to improved rates of prescription. You can see that the rate of anticoagulant use went from about 50% in the Coumadin era to now about 60 to 65%, so certainly better. But this still leaves a significant proportion of patients being untreated with regards to their stroke risk related to AFib. Aside from the issue of low rates of prescriber use, there are also issues on the patient end with long-term compliance. So this is another study looking at, again, tens of thousands of patients, and you can see that the rates of overall adherence over the course of a year for both Coumadin and the DOACs hover somewhere around 50%. Compliance tends to be better with the DOACs than with Coumadin. Encouragingly, it does look that patients who have a higher stroke risk do tend to have better rates of adherence. So this may suggest that when patients are appropriately educated and informed about their personal risk of stroke, that they may be more motivated to keep up with their medications in the long term. So given the challenges that we've discussed with long-term application of oral anticoagulation to our patients who are at risk of stroke due to underlying AFib, what are some of the other options for treatment that exist, and what are the current guidelines regarding how to consider them in the overall decision-making process? So in the most recent update to the AFib guidelines, there was a new Class 2B recommendation that was included, suggesting that we should consider percutaneous left atrial appendage closure in patients with AFib at increased risk of stroke who have contraindications to long-term oral anticoagulation. So going back to the patient that we discussed at the beginning of today's talk, patient WJ, he would certainly be potentially a good candidate as he had both an elevated stroke risk and had a prior episode of really life-threatening bleeding. So once the decision has been made to consider a patient for left atrial appendage closure, what are some of the ways that we can accomplish that? So the devices pictured here are all available and in use in Europe. And the first two on the left, the Watchman and the Amulet, are used in Canada. In the US, the only FDA approved device that we have for this indication is the Watchman device. You can see that these four have a lot of similarities in their device design. They are all placed from an endovascular approach with some sort of mechanism to anchor into the trabeculated portion of the left atrial appendage and some way of trying to occlude the ostium, whether it's a disc or sort of the conformable face of the Watchman. The only device pictured here that has a fundamentally different design is the Lariat. So this is an epicardial system that requires entry from the pericardium, and it is mediated through deployment of a suture that most closely mimics the method of surgical closure. Because the Watchman is the only device approved in the US and the one that is most often seen in clinical practice, the remainder of the talk today will focus most heavily on this device. So how do we implant this device? Historically, we use general anesthesia with TE guidance. Access is through the femoral vein. We go from the right atrium to the left atrium through a transeptal puncture. The device is positioned at the ostium of the left atrial appendage as defined by visualization of the left circumflex on TE. And the device is intended to be positioned at the ostium such that more of the body is distal to the ostium, thus forming a good seal. And this PTFE fabric is intended to endothelialize over the next several weeks, leading to the functional exclusion of this chamber from the rest of the circulation. At our institution, historically, these patients have been monitored overnight on a tele floor. They all get a transthoracic echo and then are discharged the next day. However, there is a growing experience and also body of published literature demonstrating the safety and feasibility of same-day discharge. So we have developed a protocol here to offer that to our patients as well, particularly in light of COVID and trying to be mindful of hospital resource utilization. So this is one example of a single center study from Vancouver, including about 75 patients. Patients were identified in the initial clinic evaluation as a potential candidate. And as long as patients were amenable, they were sort of put on this pathway. Their procedures were scheduled as first or second case in the morning. The procedure had to be technically successful without any intra-procedural complications. They were monitored in a post-procedure recovery unit similar to our ICRU with telemetry for at least 5 hours. All patients had a transthoracic echo before discharge. And then at a mean follow-up of around 6 months, all of these patients were complication-free, suggesting again that it is safe to discharge patients on the same day. So moving next to delve a bit into the details of the Watchman device and its pros and cons. So a few months ago, the latest iteration of the Watchman device, the Flex, became FDA approved and is now in use here at UW. There are a lot of design improvements that are intended to address various shortcomings of the prior generation device. Most notably, the distal end is now closed, which makes it softer and much more atraumatic as compared to the open struts of the previous generation device. In the IDE study, before this device was approved, there was an extremely low rate, around 1% of pericardial effusion seen. The device also has more nitinol struts that are intended to make it more flexible and better able to conform to the irregular shapes of the left atrial appendage. It's also much shorter, which means we can safely implant it into shallower anatomies. And there are also more active fixation anchors distributed at 2 different levels of the device as compared to before where they were all on one level. Again, intended to anchor into the trabeculae and reduce the risk of device embolization. The device comes in 5 sizes, able to treat an expanded range of anatomies. So we can now treat appendages that are both smaller and larger than was previously possible. So what do the data tell us about how this non-pharmacologic option compares to our traditional medical therapies? So the initial pivotal clinical trial of the Watchman device was reported in the PROTECT AF study. About 700 patients were randomized to Watchman versus Coumadin, which was all that was available at the time. The mean CHAD score of this group was around 2.2 to 2.3. And after nearly 4 years of follow-up, left atrial appendage closure met pre-specified criteria for non-inferiority for stroke, systemic embolization, and cardiovascular death. It also met pre-specified superiority criteria for cardiovascular and all-cause mortality that was mostly attributable to lower rates of major bleeding. However, there was a concerning signal for a relatively high rate of procedural complications. Notably, there was a 4.8% rate of serious pericardial effusions that required some sort of intervention, whether percutaneous drainage or surgery. And in contrast, there was a rate of about 7.4% of major bleeding seen in the warfarin group. So the primary efficacy endpoint in this study was the composite of ischemic events, stroke, systemic embolization, and cardiovascular death. You can see that numerically the rates of the primary endpoint were slightly lower in the device group compared to the warfarin group, thus meeting the non-inferiority cut point. The primary safety endpoint was a composite of major bleeding as well as procedure-related complications. You can see that the temporal distribution of the safety endpoint was quite different in the two groups, not surprisingly. So in patients randomized to the Watchman device, most of the complications occurred right around the time of the index procedure. And then late complications were relatively uncommon, as opposed to the warfarin therapy arm, where there was sort of a linear increase in events over time. Because of the high rate of procedural complications seen in PROTECT AF, the FDA required a second randomized controlled trial before granting approval to the device. So this was the PREVAIL study. About 400 patients were again randomized to left atrial appendage closure versus Coumadin. The stroke risk of this cohort was slightly higher than that of the initial PROTECT AF study. Around this time, the CHA2DS2-VASc score was validated as a better way of more granularly defining stroke risk with AFib. So the mean CHA2DS2-VASc score of this group was around 3.8 to 3.9. At a period of 18 months of follow-up, the primary ischemic endpoint, the numerical rates of events in the two arms were similar. The overall rates were much lower than what was expected compared to historical data based on the CHA2DS2-VASc score of the group, leading to the non-inferiority cut point not being met. There was a significantly lower rate of procedural complications, and specifically with regards to pericardial effusion, there was only a 1.5% rate seen in contrast to the nearly 5% rate in the earlier experience. So again, here you see this is the Watchman arm. This blue line here is this is the Coumadin arm. This is the Watchman arm. And you can see that numerically, the rates of the ischemic endpoint in the two groups seem to be quite similar and were similarly low. The predefined non-inferiority threshold was not met with the primary efficacy endpoint. The study authors also included what they called a late ischemic efficacy endpoint. The purpose of this was to try to separate the impact of the periprocedural strokes, which more commonly tended to be related to things like air embolism at the time of device implantation. They were trying to separate those events out from the ones that could be attributed to the mechanism of stroke and AFib that the Watchman was designed to address, to try to understand the true efficacy of the device once it was successfully implanted. So this was defined as stroke or systemic embolization more than a week after randomization. And in this case, the non-inferiority of the device group to the control group, the Coumadin arm, was achieved. So each of the pivotal trials had an associated registry, resulting in a cumulative data set of a few thousand patients. And you can see that over time, there was a significant decrease in the rate of procedural complications. Notably, in the PREVAIL study, there was still a large proportion of implanting operators who were either first-time implanters or otherwise relatively low volume inexperienced operators. And the rate of pericardial effusion was still significantly lower than in the initial trial. So this suggests that there was not just increase in individual operator experience, but also an important impact of changes in the implant techniques over time. There were also two large prospective registries designed to capture outcomes in the real world, which we'll touch on later. The largest and most up-to-date review of the current experience in this country was just recently published a few months ago in JACC. This is the results of the NCDR left atrial appendage registry, capturing the outcomes of over 38,000 procedures performed by 1,300 physicians at nearly 500 hospitals. The median case volume was about 30 cases per hospital, but there was a lot of variability across the cohort, with some hospitals performing 50 to 100 cases a year. On average, the patients were around 76 with the CHA2DS2-VASc score of 4.6 and a Hasbled score of 3. So a older, sicker, riskier population than was initially studied in the pivotal trials. Despite the higher risk profile of this group, there was a 98% rate of procedural success, and the overall rate of major procedure-related complications was quite low at around 2.2%. And again, the rate of pericardial effusion has continued to remain low after the experience in the initial PROTECT AF study. You can also see here that the rate of really catastrophic things like death, major vascular complications is exceedingly low, around 0.1 to 0.2%. So at this point, we've accumulated nearly 20 years of experience with and data on the Watchman device amongst all the currently available devices for left atrial appendage closure. It's the one with the most data and the largest body of experience. And there are some ongoing randomized trials that will continue to answer some of the remaining questions with regards to this device. So again, going back to our patient, WJ, who had longstanding AFib and a life-threatening bleed on apixaban, how do we approach and discuss these options with him? So of course, one option is to keep him on just an antiplatelet agent, to keep him just on aspirin. We know based on historical studies that aspirin is better than than being on nothing at all, but certainly much less effective than Coumadin at reducing stroke risk. We know that there is some additional benefit to adding Plavix, but again, that's balanced by an increased risk of major bleeding. There's the option of trying him again on apixaban or some other anticoagulant agent. And then there's the option of considering a non-pharmacologic alternative. So in helping our patients understand the risks and benefits of these different choices available to them, with the Watchman device, there is going to be an upfront risk of peri-procedural events because any procedure, no matter how safely done, is still an invasive procedure. However, this is balanced over time by reduced bleeding events as well as overall mortality. So once the Watchman device is implanted, there is an ongoing management regimen that also is part of the discussion and decision-making process with these patients. In the initial pivotal trials of the Watchman device, the regimen that was used, somewhat arbitrarily chosen. There certainly wasn't any sort of strong evidence to support the superiority of this approach, but all the patients were discharged on an oral anticoagulant, which at the time was Coumadin, as well as a baby aspirin. All patients underwent a surveillance transesophageal echo at 45 days, and as long as there was no major residual leak around the device and no device-related thrombus, these patients were then switched to ADAPT regimen of Plavix and aspirin for a total of 6 months post-procedure, at which time point they underwent another surveillance TE. And again, if things look good, they were then put on maintenance therapy with a full dose aspirin. In current clinical practice, that regimen is very rarely followed and certainly not to the T. And because of the way the adjunctive pharmacotherapy was applied in the initial Watchman trials, when the FDA initially approved this device, the wording of the indication was that Watchman was approved for patients with AFib at elevated stroke risk who were eligible for short-term anticoagulation, but not good candidates for long-term anticoagulation. And that was sort of confusing and led to, I think, a lot of confusion about which patients really qualified to benefit from this therapy. In reality, I think that the patients who most stand to gain the most from this therapy are those who are really ineligible for even short-term anticoagulation. And so in an effort to try to assess the outcomes of the Watchman device in those truly ineligible for Coumadin, the ASAP registry was designed. Again, this is not a randomized study, but it was a prospective multi-center registry where patients were implanted with the Watchman and the initial period of oral anticoagulation was bypassed. So all patients were put on DAPT for 6 months and then ultimately transitioned to a baby aspirin alone. And you can see that in this cohort, the mean CHA2DS2-VASc score was relatively high. It was around 4.4. And based on historical data of aspirin in patients with this CHA2DS2-VASc score risk, they expected a rate of ischemic stroke of around 7.3%. Again, looking at historical data, there was an expected stroke rate of 5% if Plavix was added to aspirin. So some reduction in the rate of stroke with DAPT as opposed to aspirin monotherapy. And in the patients who underwent implantation with the Watchman, in addition to being treated with DAPT, there was an observed rate of stroke of 1.8%. Corresponding to a relative risk reduction of 64% compared to medical therapy alone. The Evolution Registry was a larger prospective cohort study, this time conducted only at centers in Europe, also with the intent of understanding outcomes in patients who were deemed ineligible for even short-term anticoagulation. As you can see here, there was a plethora of different anticoagulant and antiplatelet regimens that were used after Watchman implantation. So it was up to the implanter's discretion. The vast majority of patients were not on anticoagulation. So only 27% were on anticoagulation after Watchman, 60% were on DAPT. A significant minority, 6%, were on nothing at all. And 7% were on a single antiplatelet agent, most commonly aspirin. On average, patients who started out on anticoagulation stopped it within 3 months, and those who started on DAPT stopped it within 6 months, although there was, again, wide variability. And once the transition was made from the initial pharmacotherapy regimen, a significant proportion of the patients in this cohort ended up on a single antiplatelet agent, again, usually aspirin. And very few people remained on oral anticoagulation. Even with this wide variety of adjunctive pharmacotherapeutic regimens, there was still a very significant reduction in the relative risk of stroke that was seen in this group, as well as other ischemic complications like systemic embolization in comparison to what would be expected from historical studies based on the CHA2DS2-VASc score of the group. There was also a decrease in the observed bleeding rate, again, compared to historical data. It's important to note that in this study, there were 28 patients at the time of routine TE, corresponding to a 3.7% proportion of the study group that did have device-related thrombus, and this was not correlated to the medication regimen that was used. The ASAP-2 study is a randomized trial seeking to address this question of whether it's safe for patients to undergo Watchman implantation and bypass the initial bridging therapy with oral anticoagulation. So these patients are deemed ineligible for oral anticoagulation by at least 2 physicians. They are then randomized to either Watchman plus 3 months of DAPT with aspirin and Plavix, compared to the control arm, which is a single antiplatelet agent. So usually that's going to be aspirin. The only time when people in the control group will be allowed to be on DAPT is if they have some other indication like recent coronary stent implantation. And then these patients will be transitioned to a single baby aspirin alone at 3 months, and then everything will be stopped at 1 year. So this study, I believe, has completed enrollment, but the initial results have not yet been reported. So there are still some issues related to the device design that lead to some limitations of this technology. So every form of endovascular percutaneous left atrial appendage occlusion has some related occurrence of residual leak, which for the Watchman device was defined in the trials as being greater than 5 millimeters in width, the Doppler jet on TEE, as well as some related risk of device related thrombus. So that's thrombus on the left atrial facing surface of the device. With regards to residual leak, the mechanism by which it occurs varies depending on the mechanism of closure. So with the Watchman device, it tends to have areas where it may not completely oppose against the wall of the ostium. Again, they have seen lower rates of significant residual leaks with the newer Flex device due to the increase in the conformability of the new design. But the long-term follow-up data for that is not yet available. With the Lariat device, there is a gradual loosening of the suture over time, leading to a central leak. With the Amplatzer device, which has this distal anchoring lobe and then a disc that sits over the mouth of the appendage, if the device is deployed in an off-axis position with insufficient tension on this disc, it may not sit flush here and then again lead to leak around the device. Some other factors associated with increased incidence of residual leak are a larger left atrial diameter with regards to the Watchman that can result in less device compression. And then also patient factors include permanent as opposed to paroxysmal AFib. With regards to the historical data on surgical ligation, we know that there is a high rate of persistent leak and incomplete closure. And in the surgical literature, it's been pretty well established that these are associated with higher rates of stroke or systemic embolization. Interestingly, the risk is higher with smaller leaks, which is not the case for percutaneous closure. So residual leaks are also very common after percutaneous closure. In the Watchman studies, there were rates of up to 40% that were seen, but the significance of these leaks is less well established. So in PROTECT AF, residual leaks were seen in 32% of patients on routine surveillance TE at 12 months, but there was no statistically significant relationship between the presence or even the severity of the leak and rates of ischemic stroke or systemic embolization. TE is considered the gold standard for device surveillance after this procedure. It's important to image the device and the appendage in multiple views because of the irregular anatomy of the left atrial appendage. In detecting residual leak, a lower Nyquist limit has to be used to detect low velocity flow. There has been increasing interest in using cardiac CTA for device follow-up. Some benefits of CT include that it's non-invasive, it's less operator dependent. Also, the early studies of CT show that it is more sensitive, although the ultimate clinical meaningfulness of detecting some of these lower rates of residual leak has yet to be established. So this was a study of a single center experience where up to 28 patients were followed routinely with both TE and CT. And at 3 months, there were 2 leaks detected on TE and 18 leaks detected on CT. And this largely reflects the difference in the way residual leaks are defined for these two imaging modalities. For CT, a residual leak is just any contrast that's seen behind the device. And so we may be able to detect really tiny leaks that are, 1 or 2 millimeters in diameter. In picturing the devices on the 2 different imaging modalities, we again see that there are different mechanisms by which residual leak can occur. So with the Watchman device here, you can see an area where the device is not really touching the wall of the ostium. And there's also a little bit of malapposition on this rim here. And indeed, that is the site at which residual leak can be seen with resulting flow behind the device. With the Amplatzer device, which has that dual lobe and disc design, the off-axis position, so the device itself is here, and the blue schematic is how ideally it should be positioned. You can see that the disc is really not exerting much tension on the opening of the ostium, and it's not lying flush. There's this sort of hinge point here. This is data from the evolution registry, and you can see that there was similarly low rates of ischemic stroke seen when patients had mild or moderate leaks. So these were leaks of up to 5 millimeters. And it wasn't until the leak was at least 5 or greater that there was a numeric increase in the rate of ischemic stroke. However, the study was underpowered to show a significant difference. So ultimately, there was no statistical significance seen. Another complication related to percutaneous left atrial closure is device-related thrombus. And again, it's not well understood what results in this. So it may be related to device design. So for instance, larger left atrial appendage diameters that require the use of a larger device with more foreign material facing the bloodstream is one risk factor. There are also patient characteristics, things like individuals' risk of stroke with regards to their CHADS VAS score, and also being in permanent as opposed to paroxysmal AFib. And certainly from a mechanistic standpoint, it seems possible, if not probable, that there may be some relationship to post-procedural pharmacotherapy. But again, all the data that we have so far, which comes from non-randomized studies, does not show a significant association in the incidence of DRT with adjunctive pharmacotherapy. Usually device-related thrombus is detected in otherwise asymptomatic patients at the time of a routine surveillance TE, but it is associated with an increased risk of stroke or systemic embolization. In terms of what results in DRT, any of our nitinol-based devices promote a fibrin-based healing response that is overall desirable. This transitions into subsequent ingrowth of smooth muscle and connective tissue that, based on animal and human autopsy studies, is thought to occur within 4 to 6 weeks. And it may be that DRT is sort of a deviation from this normal process where there is excessive thrombus formation rather than a transition to connective tissue. We know, again, from human autopsies that in some instances, complete coverage with tissue does not occur for years. Again, a graphic representation of data from the evolution registry showing that there was no significant association in the incidence of device-related thrombus with various pharmacotherapeutic regimens after Watchman implantation. In cases where we are following these devices with cardiac CTA as opposed to TE, we may be picking up lower grade levels of thrombus formation called low-grade hypoattenuated thickening that so far, based on our limited data and experience, seems to be transient and likely benign. So this is similar to the hypoattenuated leaflet thickening that's been described in patients after TAVR, where we may just be detecting a point in the spectrum of normal healing of the device. In this cohort of about 300 patients that were studied with both TE and cardiac CT at a single center, 7 patients, 1.4% of the group, had definite DRT at 1 year, and out of these 7, 2 had an ischemic event. In our institution, the vast majority of these patients are followed with TE. So I just wanted to show a few examples of what DRT looks like on TE. So in the upper panel here, you can see that there's sort of a gutter next to the device where there's some thrombus that has formed. Here you see an example of a pedunculated thrombus that may be attached to the metal insert of the Watchman. The newer Watchman Flex device has a recessed metal insert so that much less metal is facing into the left atrium with the hope of reducing the incidence of this type of thrombus. And this is an example of a laminar type of thrombus. So we have accumulated a lot of clinical experience with and results related to the Watchman device, but there are still some important questions about optimal patient selection, what is the ideal pharmacotherapeutic regimen, as well as what can we do to minimize the incidence of things like residual leak and device-related thrombus. So there is a study that just began enrollment this summer called Champion AF, which most closely mimics the decisions facing our patients today, and also is intended to study a lower risk population of patients who may not have such a strong contraindication to oral anticoagulation and want to consider a non-pharmacologic alternative. So these patients are required to have a CHA2DS2-VASc score of at least 2 in men, at least 3 in women, so moderate stroke risk. They're being randomized to the newer generation Flex device in comparison to NOACs as opposed to Coumadin. And again, the primary endpoints are sort of the usual ischemic issues as well as bleeding, and these patients will be followed out to 5 years. There is also a randomized controlled trial that is a study of the Amplatzer device, again, looking at a population of patients with non-valvular AFib that are at somewhat lower risk. So again, not patients with strong contraindications necessarily for oral anticoagulation. And these patients are being randomized again to DOACs as opposed to Coumadin. So with regards to our patient WJ, he was actually initially referred to me for treatment of his mitral valve. And it was only after reviewing his history and meeting him and his wife that the idea of considering him for Watchman came up. So I had a discussion with his referring physician and of course the patient and his wife. And the decision was made because he was extremely frail and they lived quite far away to actually do both procedures in the same setting, which is certainly not our default practice, but he underwent placement of a MitraClip NTW and a 30 millimeter Watchman at the same time. And I'm sorry, it looks like none of my videos here are playing. So intraprocedurally, the TE showed really trace residual MR, and the final left atrial appendogram after Watchman implant did not show any significant leak around the device. The post-procedure echo showed good results of the MitraClip and no pericardial effusion. As you know, we very rarely can see the Watchman device on TTE, but there was no evidence that it had embolized into the heart. The patient was discharged on DAPT with Plavix and aspirin. He returned for follow-up TE on post-procedure day 54. He had one moderate residual leak here that was measured at around 4 millimeters and no device-related thrombus. So given his significant risk of bleeding, we elected to transition him to a baby aspirin alone at that time. In conclusion, there is a cumulative risk of stroke and bleeding that both increase with increasing age. Oral anticoagulation remains the standard of care for most of our patients with AFib who are at increased risk of stroke. However, in those who are not good candidates for long-term anticoagulation, the current guidelines do recommend at least considering left atrial appendage closure as an alternative. And of course, there is an upfront risk of undergoing a procedure, but the data shows that this is balanced over time by reduced bleeding and overall mortality. However, important questions do remain regarding optimal patient selection, adjunctive pharmacotherapy, and how to minimize device-related long-term complications. Thank you so much for your time and attention. I also wanted to take a moment to thank Jamie McCabe, Bill Lombardi, Mark Reisman, and the rest of the interventional cardiology team. Everyone's really gone out of their way and above and beyond to help me get started and have been incredibly supportive, scrubbing my more challenging cases with me, and just really being a wonderful team to work with. So I really look forward to continuing to grow with this group, and I welcome any questions that you may have.